Well, first of all, let me just say that it's a tribute to AK's dedication and interest in this area to be able to participate in this first, our inaugural Frontiers in Intraoperative Cardiac Tissue Identification. This is an area that had a tremendous amount of interest at the nascent time of congenital cardiac surgery, when we had very little in the way of therapies. But as time has evolved, we have ignored it in many respects, kind of assuming that these complications would be inevitable, that we didn't really need to advance the field in any respect. But clearly that is absolutely wrong. So as an introduction, I'd like to maybe just walk through how cardiac surgeons have approached this problem of identifying conduction tissue in the cardiac tissue, and how the field has evolved. So this is one of the very, very early papers looking at the complications of heart block in children. This was from 1971, British Heart Journal, and doctors Frieda, Kaplan, and Helmsworth kind of defined the problem. And what they said was that the incidence was getting better. And if you look at this graph here, from the late 50s to early 60s to the late 60s, in fact, I think things were getting better in the sense that, yes, the incidence of complete heart block in the early postoperative period was going down, and the incidence of permanent heart block was going down. And their conclusion was that this is a solved problem. Clearly, that's not correct, but nevertheless, I think it shows the approach and the attitude that the community had, at least, for this problem. The problem, however, was significant. And if you look at this table on the right, if you look at mortality, we would be shocked today to see these kinds of numbers. First of all, without complete heart block mortality of 13%, but at least double that if you had complete heart block. So even though it was the incidence was going down, the severity of the problem was still there. Well, where did we progress from here? Well, there was further work that was done. This is a paper that in many ways was sort of one of the landmark papers published in the late 90s. The senior author was Ed Walsh from our own electrophysiology department, looking at the postoperative heart block and what was the outcome of these patients. And this is heart block from day 0, in other words, immediately after the surgical procedure. What was the evolution of the heart block in the first few postoperative days? And this has now become the most often quoted or cited publication when people are trying to make a decision as to when does the block become permanent enough for us to implant a pacemaker in a child versus continuing to observe. And what they noted in their study, and this is a relatively small number of patients, 54 patients, in fact, what they found is that there is really a plateau. And that even though you may start with a large number of children with initial block, 50, the actual number that ended up with more longer term, more permanent heart block was really a fraction of that. And in that sense, it gave surgeons the confidence that waiting a few days was actually of benefit in the sense you would avoid an unnecessary procedure. So that was definitely an advance in that we could now control their rhythm by temporary pacing, but then observe the kids over a longer period of time. So where did we go from here? Well, one of the problems, however, was that if you went ahead and did implant a pacemaker, as is shown in this X-ray up on the top, in fact, the problem was that in children, the durability of pacemakers is not the same as it is in adults for a couple of reasons. Number one, the leads are epicardial by necessity because their veins are small and transvenous system can often lead to obstruction. And therefore, in small children, our only option is really epicardial. With the advent of the steroid-eluting leads, which is what is shown up here, things improve, but still the freedom from pacemaker replacement is shown here. This is in years, from 0 to 5 years. By year 3, the curve begins to fall, and by year 5, half of the children had required some sort of intervention for their pacemaker. So not the same experience as in adults, where often once you put in the pacemaker, you can go for a decade or two. Really, it's only the battery change that becomes an issue. When they analyzed in this study what were the main causes, they were all of the above. Some of them were pacer leads. Some of them were battery depletion, because the amount of voltage that's required to capture on an epicardial system is a little higher. And then in others, there was a problem with the pacer generator itself, which is much, much more rare nowadays. Well, what's the economic impact of this? Quite significant. This is a very nice study looking at the impact of pacemaker placement, uncomplicated versus complicated pacemaker placement, and they divided it up into patients with and without congenital heart disease. And what we note here, this is defibrillators in the gray, pacemakers in the black. But if you look at these numbers down here, it's staggering. This is a relatively old paper. This is about 10 years old. So these numbers are much higher. And this is the actual additional cost per hospitalization of the need for requirement for a pacemaker. And part of this reason is observation time in a cardiac intensive care unit. If you have any complications and during that period of time, if you look at this central area with congenital heart disease, not only does it increase the cost, and over here is the length of hospital stay, also increases substantially. So it could add easily another week, another 2 weeks sometimes if you have a device-related complication. Fortunately, those are relatively rare now, but nevertheless, it gives you an idea of at least the economic impact, much less the medical impact. So where have we been, or what do we rely on? Well, sad to say, we still rely on this original publication in Thorax in 1983 by Anderson and Becker and Shin Ho, who basically did a series of anatomic dissections and histologic studies to not only determine what the AV node looks like and the conduction system looks like under histologic analysis, but also its location. And what they did was they published this very, very important paper showing the general and most common area where they identified at different lesions, the conduction system. And this is what surgeons have used to make decisions about corrective procedures and location of sutures, patches, and interventions, as well as tissue resection. And by and large, it's been actually pretty accurate for the majority of procedures, especially the simpler ones, such as complete AV canal defects or simple VSDs. As we start to do more complex procedures, however, that's become a problem. It's much less predictable. So clearly there's a need for new technology and advancement in the technology. And I very much look forward to the discussion today and the presentations relating to this topic.